Now, this part will discuss the electrocardiogram or the ECG, also known as an EKG. This is the recording of the electrical changes that are happening in the myocardium during a cardiac cycle. And it depends on the heart's ability to conduct the action potential. So it really depends on the SA node and the conduction system that we discussed previously. All of the waves and the deflections that we find on a normal EKG include these different parts. So there is a P wave, and that means that the atrium is depolarizing, and that happens right before atrial contraction. There's also a QRS complex. That complex is made out of 3 different waves together, and this is when the ventricles depolarize, which means that the ventricles are about to contract. And then there's a T wave that corresponds to the repolarization of the ventricles, which happens right before ventricular diastole. The PQ or the PR interval is the time that it takes for the cardiac impulse to travel from the SA node down to the AV node. And the recording of the atrial repolarization, which is the atrial diastole, is pretty much hidden within that huge QRS complex that happens due to ventricular depolarization. So what does this all mean looking at an image? So this is an normal EKG, and you can see here this is one wave, and then this is another set of waves. So we'll talk about one of these. And for these waves, you do want to know the name. You want to know what is happening in the atria. So are they depolarizing or repolarizing or in the ventricles? And what is happening in relationship to the muscles? Are they contracting? So is the chamber going through systole? Or is it relaxing, meaning is the chamber going through diastole? So we'll take it one part at a time. So again, the P wave, that represents the depolarization of the atria, both atria, which means that the atria is about to contract. So your P wave represents atrial depolarization and atrial contraction, or systole. The QRS complex, that represents the depolarization of the ventricles. And again, because the ventricle muscles, ventricle walls are thicker, you can see here that it gives you this bigger complex, compared to the P wave. So QRS complex, again, is due to the ventricular depolarization, and that happens right before ventricular systole. Now the T wave is the recording of ventricular repolarization, which corresponds to what happens right before ventricular diastole. So we talked about the ventricles and repolarizing. We talked about the atrium depolarizing, but we really didn't mention anything about the repolarization of atrium. Well, that happens at the same time as this QRS complex, and because this is such a bigger of a change, the EKG is going to record the QRS complex and kind of ignores the atrial repolarization. So that repolarization is happening somewhere in here, but it does not have its own wave or deflection. Now the PQ interval, this interval, sometimes, if you cannot see this Q part, we use what is known as the PR interval. That corresponds to the time where the action potential goes from the SA node down to the AV node. For the clinical application, arrhythmias are extremely important because they are common to happen. So an arrhythmia is an altered heart rhythm. So instead of having that regular rhythm of our heartbeat, there is some kind of abnormality, and that again is known as an arrhythmia. There's several different kinds of them, and we'll go over some of those. So tachycardia is an abnormally fast heartbeat. The normal heart rate is between 60 to 80. Some textbooks says 70 to 80. So that is within your normal range. Tachycardia would be a heart rate that is higher than 100 beats per minute at rest. So if you take somebody's heart rate after exercise, it is obviously going to be more than 100. But if it's at rest, that's your clue that that this is a case of tachycardia. Bradycardia is an abnormal slow heartbeat less than 60 beats per minute at rest. Flutter would be a rapid contraction of the heart chambers between 250 to 350 beats per minute. That's known as flutter. While fibrillation would be even more than that, at a point where there really is no actual contraction happening, because these beats are just so fast that there really isn't any time for the myocardium to contract and relax. So these are more of uncoordinated, chaotic contractions of the different parts of the myocardium. If it happens in the atria, so atrial fibrillation is not life-threatening on its own, but what does happen is that the blood can become stagnant in the atria, meaning that it's hard for the blood to circulate and move down to the ventricles because it's lost the atrial contraction. So the blood remains stagnant in the right atrium and can start to clot. These blood clots then can start sending out what are known as like emboli, showers of emboli, and these little emboli can lodge into and lead to either a stroke or a myocardial infarction and so on. So, but the atrial fibrillation on its own is not life-threatening and can, if it's reversed before these blood clots happen, then we're good. If it is diagnosed later on where a blood clot has occurred, you really have to give the patient blood thinners and take care of that blood clot before you return them back to normal SA rhythm. Ventricular fibrillation, though, is fatal. Okay, VFib, where you have these uncoordinated, chaotic contractions of the ventricular myocardium, that is going to decrease drastically the blood pressure and the oxygen that is reaching the tissues and the brain and the heart itself, so that could be fatal. Premature beats, and that's something that we all pretty much experience every now and then, where you have a beat that happens before the expected cardiac cycle. And again, you can kind of feel that. It's within certain limits, it's considered normal. And it often originates from an ectopic region, meaning that instead of getting the impulse from the SA node, that extra premature beat originated from somewhere else in the heart. An ectopic pacemaker, we do have like these secondary pacemakers. So we know that the pacemaker of the heart is the SA node, but if it's damaged, the AV node can take over. Okay, so your SA node usually sends out impulses at a rate about 70 to 80 or 60 to 80 impulses per minute. The AV node is much slower, so it sends impulses about 40 to 60 beats per minute, but it's a lot better than nothing. So if, again, damage to the SA node can lead to the AV node taking over, and that is known as a secondary pacemaker. Know also that even if the AV nodes are damaged, the Purkinje fibers can take over, and those are very slow. They're about 20 to 40 beats per minute, but again, definitely better than no beats. An artificial pacemaker is a device that is implanted surgically, artificially, hence the name artificial pacemaker, and it's used to treat the disorders of the cardiac conduction system. They are implanted and they are battery operated. In the next portion, we will start with our blood vessels.